Welcome to the Registry Insider. I'm Bill Seifert, CEO for the National Registry of EMTs. And on today's episode, we're talking about violence in EMS. Certainly a difficult subject and a controversial subject, but one that the National Registry has been a part of researching. And joining me for today's episode are two of our fellows from our research program, Jonathan Powell, as well as Chris Gage. Gentlemen, thank you both for joining me today for the conversation.
Yeah, thanks. We're happy to be here.
Yeah, thanks.
So obviously in the lead off here, I talked about a publication or publications, I should say a couple. Tell us what those publications are and share it with the audience and kind of what are the high level findings from them.
Sure. So, starting back in 2020. So back in 2020, we wanted to take a look at the type of violence that EMS clinicians were experiencing in the field. You hear anecdotal evidence that this happens or X happens, or you see a news story. But until we really measure what's going on from a national perspective, it's hard to put a number to it. And it's hard to really start working on intervention and how to lead to less EMS clinicians being assaulted or experiencing violence. So we went ahead and took the recertification profile. We grabbed 13,000 respondents from a survey.
So the recertification profile, I'm sorry to interrupt, but that is the people who recertify their national EMS certification with NREMT. That's the cohort you're talking about.
Yeah, so the group of people from 2019 to 2020 that were recertifying, they had the opportunity to take a survey that we asked a little bit about hazards in terms of violence, in terms of occupational exposures, and then injuries that they might experience. And so the manuscript that you mentioned was us taking all of that information, putting it together, and looking at it all in one holistic piece. That way, we're not just looking at violence by itself, but violence in the face of exposures, violence in the face of injuries, to make sure that we have a good understanding of what it is that we're really measuring.
Okay, good. And another, Chris, your one that you worked on as far as an abstract. Tell us a little bit about that.
Yep. So this abstract came also from a recertification period. It was 2020 to 2021, though. And it was asking about behavioral health emergencies and really asking about their education, their continued education over the last year before their recertification cycle. And it was asking them, do you have training for de-escalation training? Have you had chemical restraint training? And have you had physical restraint training? If you had all three of those in the last year, then we considered you being prepared for a behavioral health emergency. And we actually found that a third of all the paramedics were not prepared according to those categories. They were not prepared for behavioral health emergencies. But luckily, if you had a violent patient protocol with your agency, you had an odds ratio of 4 of being prepared. So protocols really do help because they kind of force you into being prepared due to the training that you're going to get for your agency.
So in addition to that finding, which a third you said were not prepared?
We're not
so
prepared.
2/3 were prepared, which is
correct.
Encouraging.
Which is good, yeah.
So any other high-level findings from both of your publications related to that?
Yeah, sure. So Chris mentioned measuring de-escalation training. We looked at that in our study as well. Specifically, we also looked at chemical restraint or physical restraint training, thinking about all the tools that might be in a toolbox for someone who's dealing with a violent patient. What we found were that those that had de-escalation training in the past 12 months had a lower odds of experiencing violence in the workplace. While those that had like restraint or physical restraint training, they actually had no change in the violence that they were able to see. And so in this case, I kind of liken it to if you're given a hammer, a lot of things look like a nail. And so we want to make sure that our EMS clinicians or the EMS clinicians that are working in the field have the right tools in their toolbox to be able to make those decisions that lead to the best possible outcome for not only the patient, but for the clinician as well.
And there's reference to this in our recent practice analysis for AEMT and Paramedic here at the National Registry, that behavioral health emergencies or mental health incidents are on the rise. And if I'm recalling correctly, our previous practice analysis showed approximately 2 to 3% of the encounters that EMS clinicians have were behavioral health or mental health emergencies. Most recently, it's up to 11 or 12%. So that's a pretty significant increase. And that was looking at NEMSIS data as well. So we know that mental health and potential violent encounters are on the rise within the EMS population. So between both of the publications, what are some of the key takeaways that we can apply to EMS, especially for our listeners who might be, or viewers who are watching, but what are the key takeaways, and also is there any other research that might be out there to really help us better understand and appreciate and respond to behavioral health and violent encounters?
Yeah, so there's a lot of other research out there that complements what we've done as well. So one of the big takeaways from my work is that de-escalation is effective, and that de-escalation can lead to a reduction in having that type of violence experienced by EMS clinicians. You mentioned behavioral health emergencies increasing. A previous study done by the National Registry Research Department showed that almost half of calls that ended up being labeled as behavioral health emergencies weren't dispatched as such. So not only are those calls increasing, but EMS clinicians don't necessarily have all the information that they need to really be prepared as soon as they walk into those types of calls.
So walking in cold to potentially a violent encounter or a behavioral health emergency that could turn violent.
Or it could be as simple as a low blood sugar that turns into a violent patient. I've been kicked in the side of the head before by a low blood sugar patient. Technically, it wasn't a violent patient. It wasn't going to be dispatched as a violent patient, but it did end up being one. I think it was in Texas a couple of years ago that EMS crew woke up a person that had overdosed with Narcan, and they stepped off the bus, and when they decided they didn't want to go to the hospital, they pulled out a handgun, shot one or two firemen, and then ended up killed by police. And that was just an overdose. That was, the assessment hadn't been done to look for a weapon or anything before they, gave him the naloxone to wake him up.
So clearly violence is on the rise. De-escalation works. It's a key thing. There is other research out there. What other takeaways, what can the average EMS clinician in the street do to better be prepared, perhaps incorporating more de-escalation exercises or drills? What else can they do?
I think one of the studies that came out in Canada that was actually presented at NAMSP last year in Austin, Texas, and what they did is the agencies, I don't remember how many agencies were, but the agencies actually put a where did you encounter violence on this patient in the EPCR. So they were able to actually click for each individual patient which ones they found that they did have some kind of cursing or violent encounter or something like that. And actually about 50% of all their EMS clinicians in that study did have some kind of violent patient encounter. So that could be an opportunity to put something in that's directly reporting to each individual incident, because a lot of times, if you go into a situation and you get cursed at or something like that, you don't report that. I mean, that's not going to be something that every single person does. But if it was something in an EPCR that was able to be, directly clicked on during each individual call, and it could be something as simple as, did you have a violent patient? Did you have a violent encounter or anything like that? And that would give us more information to understand these on a national level, on a daily level, to see if maybe it's seasonality. Maybe summer seasons are worse than winter, and it can give clinicians a better understanding about what they need to prepare for when they do go out there and for the training and stuff. As far as the de-escalation training, if you can de-escalate a situation, you don't have to get in a person's space. I mean, you don't have to get punched or hit or something like that. So the de-escalation training would be the priority one to be able to calm the situation down and not put yourself in even a further situation.
To piggyback off what he was saying, this study that he mentioned in Canada was looking at it from a EMS activation standpoint in terms of allowing you to select whether or not you would experience violence during this activation. And then when you look at that compared to our survey results, looking at, did you have a violent encounter in the past 12 months? They found about half of their clinicians had experienced this type of thing. In our survey, we found it was about 64% of clinicians that had experienced violence.
Which is higher. It's
higher in our study, but it's also a different way of measuring it. And so finding out what those different ways to measure this to make sure that we aren't falling into some kind of groupthink bubble and just believing that we have the right answers whenever we don't, it's important. So it's important for people like us to collaborate with external researchers to make sure that we look at these important questions in a scientifically bias-free possible way.
Excellent. So where can the listeners and viewers go to find both of your publications?
Yeah, so my publication is in the Occupational and Environmental Medicine Journal. It's available open access, and I imagine there'll be a link associated somewhere with this post. But it's open access for anyone that wants to read it, and we're more than open to talk about it with anyone that wants to open a dialogue.
The publication for the abstract is in Pre-Hospital Care Emergency Journal, and it's actually in the abstracts listed for the NAMSP conference for 2023.
Excellent. Okay. Well, gentlemen, thank you for what you do, in particular for having us to start to better understand violence and mental health encounters in EMS. Are there any other research publications that are, as far as related coming attractions, or other stuff you want to give a plug for while we have you?
Chris, I'll let you go first.
So I actually just got a publication in JAMA Network Open looking at the increase or the trend of layperson administered naloxone. So a lot of naloxone's been given, but we wanted to know what's the trend of someone actually giving naloxone before an EMS clinician showed up. And it's actually a significant trend that a lot more people are giving it, but it kind of makes sense because there's a lot more opportunities. Prescriptions are being given, or you can actually get it without a prescription now. There's vending machines, stuff like that. So that's the publication we have in JAMA Network Open, and it should be coming out hopefully in the next couple weeks.
Excellent.
Yeah. For me, I'm incredibly excited about our recent publication on clinical judgment, looking at those items and how the inclusion of clinical judgment items.
And reliability.
Yeah. So I'm extremely excited about that. So if I can push anyone to go read that paper, I'd love to. As former EMS educational program directors, that speaks pretty near and dear to our heart.
Excellent. And it speaks near to my heart too, because our examinations have a lot of clinical judgment on them. Also.
Yeah, and I can say on top of that, we have a couple other clinical judgment papers that are in the works that are working their way through to to strengthen the validity and reliability of that scientific communication. So I'm excited about that too.
Very cool, gentlemen. Thank you for joining me for today's podcast episode, and thank you as well for joining us. And as always, stay safe. Thank you for joining us for this episode. If you wouldn't mind, please click the like and subscribe buttons, as well as the notifications so you can get notifications of upcoming episodes. Also, for the latest and greatest happenings of the National Registry, feel free to go to NREMT.org. Thank you very much. And again, stay safe.